So ruxolitinib being the first and only for a while approved JAK inhibitor for myelofibrosis, it dominates the treatment landscape. Pretty much every trial treatment algorithm or trial algorithm or any algorithm you see is going to have ruxolitinib plastered all over the place, whether we're talking about low risk disease with symptoms or any variety of high risk disease. When you only got one trick in your bag, you're using that trick often. All right, so like you think about pitchers in baseball. Like if all they have is a fastball, they're going to be throwing that fastball almost all the time. Certainly, we want to become a pitcher that has multiple pitches, where we can start to pick and choose where ruxolitinib may fit into treatment algorithms. But for right now, it is the dominant force. Fedratinib was FDA approved in 2019 for the treatment of myelofibrosis. And there are some situations you may think of fedratinib over ruxolitinib. Certainly in patients who've had prior ruxolitinib, fedratinib is an option based on the JAKARTA 2 study. Also, there is some ad hoc or subsequent analyses that were done on the JAKARTA data suggesting that patients with platelet counts 50 to 100 may have a little bit of more benefit from fedratinib because you can deliver full dose JAK inhibition in spite of those low platelets. But I would say that ruxolitinib today still dominates most of these treatment algorithms. It's been out longer. It has a favorable side effect profile, and I think most people are very comfortable with it. Although fedratinib has entered the scene, but really we're still, I would say, a pitcher with one, maybe two pitches, and we still need to broaden our repertoire.